लाइव है, ठीक है, यू कैन स्टार्ट.
Start. Good evening, everyone. It is an immense pleasure to welcome you all for today's ISA National PG online classes. Myself, Dr. Anu Kevlani, Assistant Professor from AIIMS Nagpur, is one of the screen coordinators for today's session. The topic for today's discussion is a case discussion on pregnancy-induced hypertension with associated gestational diabetes mellitus and mild anemia. As we all know, pregnancy-induced hypertension is a challenge for the anesthesiologist, and the presence of other comorbidities can add fuel to the fire. An interesting such case discussion will be discussed on today's platform. Before we begin the session, let us invoke the divine blessings of Ma Saraswati, the goddess of wisdom and knowledge, through this Saraswati Vandana. Now, I would like to request our Honorary Secretary, Professor Dr. Sukhminder Bajwa sir, to please address the session. Over to you, sir.
Thank you, Anu. I think today the team of NASIC, they have chosen one of the most complicated case, having the PIH. When you tackle a case of PIH in your clinical practice, you are very, very much vigilant. And if that patient has anemia, there's another degree of complication, the complexity. And when it's come to the third part, diabetes, now I think the bells start ringing, what to do and how to do manage and how to really plan the things in such a way that all the three comorbidities are taken care of while taking at the same time taking care of two lives. So it's a really puzzling and very difficult for even me also to, at least devise a plan or treatment methodology in the straight go. If some patient comes to me, at least I will also so ensure the patient safety from both the maternal and the fetal side. And I think today our PG students, they will be dwelling upon this case and it will be most tough and challenging for them. But I know Madam Sunita and team, they must have prepared them in a good manner. So let's start this fun today. It's a very good class, a very interesting topic.
Thank you, sir. Now I would like to request my co-screen coordinator, Dr. Shima, to kindly introduce the faculties for today's class. Over to you, Shima.
Thank you, Dr. Anu. Good evening, everyone. I am Dr. Shima Bashir. I work as consultant anesthesia at the corporate hospital chain Amritsar. Today, we have the distinct honor of being joined by some of the most accomplished professionals, and all our moderators for today are from the same institute, and that is Maharashtra Postgraduate Institute of Medical Education and Research, Nasik. Our first esteemed guest for today is Dr. Sunita Sanklecha. Ma'am is Professor and Head Department of Anesthesiology at the Institute. Ma'am is affiliated to MUHS, ISA and IMA. Ma'am has a total teaching experience of 29 years and ma'am is MUHS approved postgraduate teacher and examiner. To her credit are 12 national and international publications and ma'am has been awarded by ISA Nasik branch for her exemplary work. Ma'am has specialty interest in high-risk obstetric anesthesia, segmental spinal anesthesia, and anesthesia for ENT and laser surgeries. Ma'am is a certified BCLS and COLS trainer. She has completed ACLS course by AHA. She has completed advanced research methodology course, and she has been panelist at various state and national level conferences. We welcome you, ma'am. Our next esteemed guest is Dr. Jayashri Sally. Ma'am is Associate Professor, Anesthesiology at the Institute. Ma'am is having a total experience of 21 years of teaching in anesthesia, and she has a specialty interest in regional anesthesia and high-risk obstetric anesthesia. Ma'am has also a fellowship in interventional pain medicine from Hyderabad. To her credit are 11 research publications in national and international journals and also one book chapter. Our next esteemed moderator is Dr. Sivani Futane. Ma'am is also an associate professor anesthesiology at the Institute. She has been in postgraduate teaching since 6 years, and her specialty interest is in neuroanesthesia, simulation, and regional anesthesia. To her credit are 11 national and international scientific papers in PubMed journals. She has been awarded Mahayuva Isocon 21 Award for paper presentation and also at World Congress of Anesthesia Conference at Prague in 21, she was selected for poster presentation. Ma'am has got International Best Research Award by International Congress for Research Excellence. And our last esteemed moderator is Dr. Kashinath Jadhav. Sir is an associate professor, anesthesiology at the Institute. Sir has a specialty interest in regional nerve blocks and pediatric anesthesia, and he has 14 years of professional experience. Sir has 10 research publications in national and international journals, and he has got an International Best Research Award by ISSN, also a COVID Warrior Award to his credit. Sir has a certificate of appreciation by DMER Mumbai for emergency work during leptospira outbreak. It's an absolute privilege for me to serve as a screen coordinator for such distinguished panel. We welcome you all. And here we have an announcement for the audience. Audience will be muted for the duration of the session. If anyone is having any queries, they can please post it in the chat box. All the questions will be addressed at the end of the session, and I request you all to keep the videos off. Now I'll hand over the stage to moderators to carry on the session forwards and introduce the postgraduates. Thank you.
Thank you, Dr. Shima. Good evening, all. Greetings from Holy City, Nashik. Myself, Dr. Sunita Sanklecha, on behalf of Department of Anesthesia, Government Medical College and Maharashtra Postgraduate Institute and MUHS Nashik, I welcome you all for today's National PG online class by ISA. I thank our National Secretary of ISA, Dr. Sukhvinder Bajwa sir, for giving us this opportunity. Our institution is a dream project of our dynamic Vice Chancellor Dr. Madhuri Kanetkar Madam and under able leadership of Honorable Dean Dr. Venkat Gite sir, we have started post-graduation in anesthesiology with 11 PG seats per year. We are affiliated to District Civil Hospital Nashik. I think Madhuri Madam knows this hospital very well. It's a tertiary care hospital with huge workload of almost 1,000 or 1,100 cases per month we are doing, and almost 400 to 450 obstetric cases per month we are doing. And that is why we have chosen this high-risk obstetric case for today's PG class. The case will be presented by Dr. Vaishnavi, she is JR2, and Dr. Pratyusha, she is also JR2. Dr. Bajwa sir, may we start the case?
Yeah, ma'am, please proceed.
Yes. Dr. Vaishnavi and Dr. Pratyusha, start the case presentation.
Thank you, ma'am. Good evening, everyone. My patient, 31-year-old female, married since 5 years, is resident of Palghar. She is Hindu by religion, housemaker, and educated till 10th class. She came to our hospital with 36 weeks of amenorrhea. She came with chief complaints of increased frequency of urination since 2 months, easy fatigability since 2 months, swelling over legs since 15 days, headache since 2 days, blurring of vision since 2 days, puffiness of face since 2 days. She is registered case of ANC with 36 weeks of amenorrhea at Rural Hospital Palghar since February 2024. Patient gives history of increased frequency of micturition since 2 months, which was insidious in onset, progressive, not associated with fever with chills or burning micturition. She gives history of easy fatigability since 2 months. She can do her daily activity without feeling tired. After walking 200 meters, she is fatigued and she can climb 15 stairs. Fatigability is relieved on taking rest. She also gives history of swelling over legs since 15 days, which is insidious in onset, initially around ankle and progressively increases throughout day, more in the evening. Swelling doesn't relieve on taking rest or lying supine. She is also complaining of tightening of bangles and rings since 15 days. Patient gives history of headache since 2 days, which is sudden in onset, intermittent, gradually increasing, present over front and back of head, relieved on taking rest and associated with blurring of vision. She also gives history of puffiness of face since 2 days, which is insidious in onset, present throughout day, not relieved on taking rest. She is referred case of pregnancy-induced hypertension with gestational diabetes mellitus. She has come to our hospital for further management in view of raised blood pressure in spite of taking medications. She has no history of epigastric pain, yellowish discoloration of skin or eyes, no history of nausea and vomiting, no history of convulsions, altered sensorium, giddiness, no history of bleeding gums or easy bruisability, no history of tingling numbness. There is no past history of major systemic illnesses like hypertension, diabetes mellitus, or convulsions. There is no past surgical history, no known drug or food allergy. She has no family history of hypertension, diabetes mellitus, and epilepsy. She is vegetarian, bowel habits are normal, sleep is disturbed due to increased frequency of urination, and no addictions. She is taking tablet metformin 500 mg twice a day before meal. And also she is taking tablet labetalol 100 mg twice a day. She achieved her menarche at the age of 15 years, having regular cycles of 30 days with 4 to 5 days moderate flow and no pain. She is primigravida. Her LMP is 8th January 2024 and expected date of delivery is on 15th October 2024. General examination. My patient is conscious, cooperative, oriented to time, place, and person. She is well nourished and afebrile. Her current weight is 70 kg. Her pre-pregnancy weight was 50 kg. Her current BMI is 27 kg per meter square. Her blood pressure was 98 per minute with good volume, regular rhythm, and all peripheral pulses palpable. There is no radial or radiofemoral delay. Her blood pressure is 168 over 112 millimeters of mercury, measured in right arm in semi-recumbent position. Respiratory rate is 16 cycles per minute. She has bilateral pitting pedal edema over lower third of the limbs. She also has facial puffiness and she looks pale. There is no cyanosis, clubbing, and lymphadenopathy. Palm print sign and prayer sign are absent. On airway examination, her mouth opening is 3 finger breadth with Mallampati classification grade 2. No loose tooth or missing teeth. Thyromental distance is 6.5 centimeters. Bilateral nasal patency is present. Her neck movements are normal. Upon spine examination, we couldn't feel the spinous process in the lower lumbar region due to edema. Systemic examination. In abdominal examination, upon inspection, abdomen is uniformly distended and longitudinal. Edema seen all over the abdomen. Umbilicus is everted, flanks are full. Stria gravidarum and linea nigra present. No scars over abdomen. All the inspectory findings are confirmed on palpation and her abdominal circumference is 85 centimeters. Funnel grip shows soft, broad, irregular, non-palatable structure suggestive of breech. First pelvic grip shows smooth, hard, palatable structure suggestive of head. Second funnel grip, fingers converging, head not engaged, and fetal movements are present. And on auscultation, fetal heart rate is 160 per minute, present over left side of umbilicus. Central nervous system examination, her higher mental function is normal. Cranial nerves, sensory and motor examinations are normal. Cardiovascular system, apex beat not palpable, no palpebral thrill, S1, S2 heard and no murmurs. Respiratory system, trachea is central, chest movements are equal bilaterally, air entry is equal on both sides and normovesicular breath sounds are heard. My provisional diagnosis is a 31-year-old primigravida with 36 weeks of gestation with preeclampsia, gestational diabetes mellitus, and mild anemia posted for lower segment cesarean section.
Okay. Pratyusha and Vaishnavi nicely presented the case. Can you tell me what are your positive findings in history and clinical examination?
Yes, ma'am. My patient has come with, she is an elderly primate with 36 weeks of gestation and her blood pressure was 168 over 112 millimeters of mercury. She also has edema over lower limb and facial puffiness. And it is associated with headache and blurring of vision which are on and off. She also gives complaint of increased frequency of maturation and fatigability and she looks pale. And for control of blood pressure, she is on medication tablet labetalol. And for control of blood sugar level, she is taking tablet metformin.
Okay. In your provisional diagnosis, you have mentioned that your patient is presented with pregnancy-induced hypertension. Can you define this condition?
Yes, pregnancy-induced hypertension is defined as elevation of blood pressure that is more than or equal to 140 by 90 millimeters of mercury in previously healthy women after 20 weeks of gestation. The readings are taken twice and 4 hours apart.
What happens postpartum? Can you include that also?
Yes, ma'am. In postpartum period, usually blood pressure resolves after 12 weeks of postpartum.
Yeah, this is also important. There are various hypertensive disorders of pregnancy. This is one of the conditions which you have mentioned. Can you tell about those conditions?
Various hypertensive disorders, patient might present with gestational hypertension, preeclampsia, which is further classified as preeclampsia without severe features and severe preeclampsia. Patient might also present with chronic hypertension or chronic hypertension with superimposed preeclampsia.
Okay, so these are the various hypertensive disorders which are observed in pregnancy. So, what are the different presentations of these disorders? Can you enumerate or can you describe these conditions and features?
Patient presentation depends upon the time of onset. And if the time of onset of hypertension is before 20 weeks of gestation, we call it as chronic hypertension. If blood pressure, if hypertension is present after 20 weeks of gestation, we can call it as gestational hypertension or preeclampsia. And to further differentiate gestational hypertension and preeclampsia, we look into proteinuria, serum uric acid greater than 5.5 milligram per deciliter, hemoconcentration, and thrombocytopenia. And these are typically present in preeclampsia.
Okay, so in your gestational hypertension, it's that way milder form. And in PIH, all these things like proteinuria, uric acid, hemoconcentration, and thrombocytopenia is observed, isn't it?
Yes, ma'am.
Is there any hepatic involvement and how will you monitor that, or how will you know that
Yes,
there is?
due to
Yes.
oxidative stress, there could be hepatic hemorrhage or necrosis in hepatic sinusoids. This will lead to increase in the liver enzymes such as aspartate aminotransferase and lactate dehydrogenase. The normal levels of lactate dehydrogenase is 142 to 80 international unit per liter, and in patients with preeclampsia, they present with more than 600 international unit per liter.
Okay, even that will indicate the severity of the disease, isn't it?
Yes, ma'am.
Why at all you want to know all these different presentations? How it is going to affect your management?
Ma'am, if patient is known to have a chronic hypertension who is hypertensive before her pregnancy and she comes for her regular antenatal checkup, we would see her hypertension and we would advise the medication, and treatment differs from patient to patient. In chronic,
Okay, yeah. If essential hypertension patient presents with pregnancy and if she is taking beta blocker as a routine, then will you change the medication?
yes, ma'am, I would advise her to stop beta blockers and I would advise her to start on tablet labetalol since it is a choice of medication in pregnancy.
So that is why you want to know different features and different types of hypertensive disorders in pregnancy, because management changes.
Yes, ma'am.
Okay. So
Yes.
can you tell me what is the etiology of PIH?
Yes, ma'am. There is no exact cause for PIH known by time. They are trying to take preventive measures in the form of calcium or and vitamin D supplementation and lifestyle modification in high risk patients. Still, incidence of PIH is high.
Yeah, and I think that is the leading cause of maternal mortality still in India. So you're running with the, just go back. Huh. What is the pathophysiology of PIH? Can you explain, Vaishnavi?
Yes, ma'am. In normal pregnancy, as you can see here, this is placenta and this is uterine cavity. In normal pregnancy, a cytotrophoblast invades the uterine cavity and it reaches the spiral arteries. So that remodeling of the spiral artery occurs and diameter of the spiral artery increases to 4 times. Also, these arteries are unresponsive to vasoactive stimuli. Uh, all
Okay,
these
so
leads to
in normal, yes.
adequate blood flow to the placenta and fetus. All these changes occurs in normal pregnancy.
Okay, means the spiral artery diameter changes and they become quite large. That is 4 times than the normal, and increased blood flow is there and with less resistance, so that fetal development occurs, isn't it?
Yes, ma'am.
So can you now explain what are the changes which occur in preeclampsia?
Yes, ma'am. As you can see here, in preeclampsia, cytotrophoblast doesn't invade the uterine cavity and remodeling of
Yes.
spiral arteries doesn't occur. So that spiral arteries remain small and constricted. And also these spiral arteries are hyper responsive to vasoactive stimuli. So that blood flow to the placenta is decreased and hypoxic injury occurs. And hypoxic injury occurs due to all these changes in preeclampsia. As you can see here in this image, in normal pregnancy, there is intact endothelium is present in vessels. But
Yes.
in preeclampsia, due to hypoxia, there is increase in anti-angiogenic factors like soluble FMS like tyrosine kinase 1 uh, and soluble endoglycin are present, and it antagonizes the angiogenic factors like vascular endothelial growth factor and platelet derived growth factor. All these changes leads to diffuse endothelial dysfunction.
Yes, very well mentioned. So this endothelial dysfunction is there with each and every vessel. Just go back. So this endothelial dysfunction is there with every vessel, and that is why it is said that PIH is a
Multisystemic
multi.
disorder.
Yes,
Yes.
yes, and all these things can be observed, like hypertension and kidneys are involved, and that is why there is proteinuria and even brain edema. Yes, I
Yes.
think now it's a quiz time. Let's have one question for audience. Which of the following biochemical marker is commonly elevated in severe preeclampsia. Creatinine kinase, uric acid, troponin, and procalcitonin. Audience can write their answers in chat box. Now I request Dr. Jayashree Sai to proceed with the case discussion.
Thank you, madam. Good evening, everybody. My question to Vaishnavi and Pratyusha is, can you tell me the risk factors of preeclampsia?
Yes, ma'am. There are various risk factors associated with preeclampsia. It can occur in at extremes of ages, that is pregnancy occurring at early ages or elderly primigravida, black race, previous history of preeclampsia, family history of preeclampsia, previous history of placental abruption, fetal growth restriction, or fetal death. It can be associated with medical conditions like obesity, that is BMI is more than or equal to 30 kilograms per meter square, chronic hypertension, diabetes mellitus, chronic renal disease. It can be associated with autoimmune diseases like antiphospholipid antibody syndrome, SLE. Preeclampsia risk increases in multiple gestation and hydatidiform bole. Cigarette smoking is a risk reductive factor for preeclampsia, but cigarette smoking causes intrauterine growth retardation.
Okay, Dr. Vaishnavi, you have mentioned all the risk factors very well. Can you tell me how does cigarette smoking reduce the risk of preeclampsia?
Yes, ma'am. Cigarette smoke contains nicotine. Due to nicotine, it simulates the release of nitric oxide, which is vasodilator, and it inhibits the release of thromboxane A2, which is vasoconstrictor. So, adequate blood flow to the placenta is preserved.
Okay. You said something about your patient that she has gained how many kgs of weight?
Approximately 20 kgs of weight.
15 to 20 kgs, right? So does this obesity increase the risk of PIH, and how does it do that?
Ma'am, in obesity, insulin resistance is present, and due to insulin resistance, microvascular changes occurs. So it will lead to the endothelial damage in obese patients.
Correct. So do you know something about a metabolic syndrome?
Yes, ma'am. Metabolic syndrome is hypertension, hyperglycemia, insulin resistance, and dyslipidemia.
Correct. So your patient has obesity and diabetes as one factors along with PIH, right?
Yes, ma'am.
Do you know any prophylactic strategies to prevent preeclampsia?
We can give prophylactically low dose aspirin, that is 75 milligram once a day, between 12 to 24 weeks of gestation. Also, we can give tablet metformin. We can supplement with calcium tablets, or we can tell patients for lifestyle modifications like low sodium diet, exercise, and antioxidant intake.
Okay. Why do you suggest antioxidants?
Ma'am, there are some studies where they can say that antioxidant reduces the oxidative stress. As in preeclampsia, oxidative stress is present.
See, oxidative stress is one of the causative factors of preeclampsia. Studies are there to support this theory, but as you said, use of antioxidants, it has not been supported as of yet, and no positive results have been achieved like as of now. Okay.
Yes, ma'am.
Okay. So, can you tell me the diagnostic criteria of PH?
Diagnostic criteria includes preeclampsia without severe feature, where patient presents with blood pressure of above 140 by 90 millimeters of mercury after 20 weeks of gestation, associated with proteinuria. And in severe preeclampsia, patient presents with blood pressure above 160 by 110 millimeters of mercury, associated with proteinuria, and either of the following, such as thrombocytopenia, where the platelet count is less than 1 lakh per millimeter cube, serum creatinine concentration, which is greater than 1.1 milligram per deciliter or 2 times above the baseline, pulmonary edema, or any new onset of cerebral or visual disturbance, and impaired liver function.
Good, Pratyusha. And what category does your patient belong to?
Ma'am, my patient belongs to severe preeclampsia.
And what factors do you support?
Ma'am, she has come with the blood pressure of 164 by 112 millimeters of mercury, and also she has a cerebral onset symptoms such as headache and visual disturbance.
So there is one symptom of CNS symptom, which is newly onset,
Yes,
along with rise in the blood pressure about 160 by 110. So that are the two factors which are supportive of severe preeclampsia in your patient. Correct.
yes.
Do you consider edema as a diagnostic criteria?
No, ma'am, edema is not considered as a diagnostic criteria.
Why not?
Because edema is less, it lacks its specificity, and also it happens in a healthy pregnant woman.
Okay. So it is common in all the pregnant patients, most of the pregnant patients, even if they are healthy and young. So that is not considered anymore. Okay. You have said there are two types, like preeclampsia without and with severe features. Do you call a preeclampsia without severe features as mild preeclampsia?
No, ma'am.
Why do you not say that?
According to ACOG guidelines, ma'am, we call it as without severe features because preeclampsia may be rapidly progressive, and we have to rapidly evaluate for the further investigations and to manage patient.
So it is a rapidly evolving disease, and you have to be very stringent. You have to monitor the patient closely so that any patient without severe features can go into preeclampsia with severe features. So there are only two groups. Okay.
Yes.
Good. As you said earlier, the preeclampsia has effects on the various systems, right? Because of
Endothelial damage, ma'am. Diffuse
correct.
endothelial damage.
Yes. So can you tell me, in your patient, she has some CNS symptoms. So what are the CNS manifestations of severe PIH?
In severe, central nervous system,
Yes, central
there
nervous
is
system.
a severe headache, hyperexcitability, hyperreflexia, eclampsia, hemorrhagic stroke, seizures, and visual disturbances like blurring of vision, scotoma, or amirosis is present in these patients.
So what is the pathophysiology of the central nervous system effects?
It can be due to loss of cerebral vascular autoregulation, vascular barotrauma, or it can be due to hyperperfusion of the brain areas due to endothelial damage.
And increased blood pressure or the hypertensive crisis.
Yes, ma'am.
Okay. What is PRESS?
This is a posterior reversible encephalopathy syndrome.
Okay. And which circulation is affected here?
Posterior circulation is affected.
It is a reversible condition, right?
Yes, ma'am.
Okay. Do you know any neurological markers of disease severity?
Yes, ma'am. Optic nerve sheath diameter. If optic nerve sheath diameter is more than or equal to 5.8 millimeter, then it will suggestive of raised intracranial pressure, and also regional cerebral oxygen hemoglobin saturation. It increases in preeclampsia. It decreases in preeclampsia. Sorry. Uh,
And what does MaxSelf do?
Maxwell increases regional cerebral oxygen hemoglobin saturation.
Correct. Most concerned as anesthetist, there is one system which we are all concerned about, is the
Airway.
airway. So what are the changes in a preeclamptic patient?
In preeclampsia, there is a pharyngolaryngeal edema, airway narrowing, or subglottic edema could be present.
Okay. And how does the patient present if she has all these changes?
Patient presenting with symptoms like hoarseness of voice, stridor, snoring, dyspnea or dysphagia, and also obstructive sleep apnea with obstructive sleep apnea.
Okay. You said something about obstructive sleep apnea. How does OSA increase the risk of PIH?
In obstructive sleep apnea, airway narrowing is present, and due to airway narrowing, there is frequent desaturation occurs. And due to desaturation, frequent nocturnal awakening is present in these patients. And due to all these changes, there may be hypoxemia, endothelial damage, hypertension, like symptoms occurs in OSA.
Okay, very good. Tell me the cardiovascular manifestations of severe preeclampsia. And how does it differ from a normal pregnancy?
There could be hypertension or left ventricular dysfunction is present. In normal pregnancy, there is increase in heart rate, increase in stroke volume, increase in cardiac output, but decrease in systemic vascular resistance is present. But in preeclampsia, heart rate increases, stroke volume increases, cardiac output increases, as well as there is increase in systemic vascular resistance is present.
Yes, correct. Do you know any biomarker to identify the cardiac dysfunction?
Yes, brain natriuretic peptide, that is BNP, is a biomarker for serious abnormality. It increases in preeclampsia.
And which other conditions you find elevated levels of BNP?
Increase in systemic vascular resistance, decrease in cardiac output, and left ventricular dysfunction.
Okay. The next system which is affected is the respiratory system, right?
Yes, ma'am.
Do you know the respiratory complications in severe PIH?
In severe PIH, there could be pulmonary congestion, pulmonary edema, or acute hypoxemic respiratory failure occurs.
And what is the pathophysiology of pulmonary edema?
There is increase in intravascular hydrostatic pressure due to increase in volume overload, and there is decrease in plasma oncotic pressure as leaky capillaries are present due to increase in vascular permeability. There is increase in left ventricular end diastolic pressure, and also there is systolic dysfunction could be present in preeclampsia.
Correct. So what is the role of POCUS?
POCUS is a ultrasonography. By this test, we can find B lines, that is interstitial edema. We can find by this sonography.
What are the findings in lung ultrasound? Can you hear me, Vaishnavi?
Sorry, ma'am.
Okay, so what is POCUS?
POCUS is point of case ultrasonography.
Point of care ultrasound.
Ultrasonography.
Ultrasonography, correct. Okay. So next, I think we have the quiz time, right?
Yes.
So we have a question for the audience.
Ma'am, we
Which
have responses to
vasodilator?
the first. Ma'am, we have responses to the first question.
Okay.
We had asked which biochemical marker is commonly elevated in severe preeclampsia.
Yes.
And we have most of the responses as B, uric acid. All the responses are actually option B.
Yes, correct.
Okay. So we'll go to the next question for the audience. Which vasodilator is contraindicated in preeclampsia due to increased risk of hypotension? A is hydralazine, B is labetalol, C is nifedipine, and D is sodium nitroprusside. You can put your answers in the chat box. Over to Dr. Kashinath Zada.
Thank you, madam. Am I audible, Pratusha?
Yes, sir.
Yeah. As we are discussing the systemic effect of this PIH, can you tell me what are the hematological changes that you can expect in such patients?
Yes, sir. As we have seen in pathophysiology, there is endothelial damage. And due to this endothelial damage, the fluid moves from intravascular space into interstitial space, which will lead to platelet activation and consumption, which further leads to reduce in the platelet count, and we call it as thrombocytopenia, where the platelet count is less than 1 lakh per millimeter cube. And the other changes which we can see is microangiopathic hemolysis, decrease in the clotting factor, increase erythrocyte destruction, and increase fibrin degradation products.
Okay, good. So that means as it is thrombocytopenia is there, you should always check for the platelet count in such patients.
Yes.
Can you tell me what are the hepatic changes in such a patients?
Hepatic changes are due to, we see the periportal hemorrhage and fibrin deposition in hepatic sinusoids. And this will lead to stretch of liver capsule, and patient might present with right upper quadrant or epigastric pain. And due to endothelial damage, there is hemoconcentration and hemolysis, which leads to elevated liver enzymes and also HELLP syndrome.
Yeah, right. That means if our liver is very well involved in such a PIH patients, and we should be always, if patient complaining of any epigastric pain, we should suspect of hepatic changes. Okay. So can you tell me what are the renal changes in such a patients?
So in renal changes, during normal pregnancy, there is increase in the glomerular filtration rate, that is 40 to 60%. And when it comes to preeclampsia, there is decrease in the glomerular filtration rate and also decrease in the renal plasma level and increase in the vascular resistance. And due to all these changes, there is glomerular endotheliosis, which leads to increase in the permeability of large molecular weight protein that leads to proteinuria. And also we can see hyperuricemia. This is due to decrease in the renal clearance.
Okay. Do you know any earliest marker of PIH in such a patients?
So the earliest marker is serum uric acid.
Why it is said so?
So due to decrease in the renal clearance and there is damage in the renal tubular reabsorption, there is increase in the serum uric acid level, and this increase is seen as early as in the pregnancy, that is around 24 weeks of gestational age.
Yeah, that's why it is considered as the earliest predictor or earliest marker of PIH.
Yes.
So, do you know any changes in the uteroplacental perfusion in PIH patients?
Yes, as we have already seen in the pathophysiology, usually there is a dilatation in the placenta, in the spiral arteries, so that blood flows normally to the placenta and to the baby. But here in preeclampsia, there is incomplete trophoblastic invasion, which is leading to decrease in the diameter of these vessels. And this will cause decrease in the placental perfusion and it leads to intrauterine growth retardation.
Okay, so you rightly said this condition is very well unfavorable for the fetus because of the IUGR. Okay, now I think we have covered the systemic effect. So now it is time for asking a question to the audience. So following are the normal findings in urine examination during pregnancy, except you have 4 options: glycosuria, proteinuria, hematuria, and bacteria. You can write down your answers in the chat box. Meanwhile, I ask Dr. Savni to continue the case discussion.
Thank you, sir. Am I audible, Pratyusha and Vaishnavi?
Yes, ma'am.
Right. So now, as we are discussing effect of PIH on different systems, and you mentioned HELLP syndrome in one of the previous slides. Will you tell me what is HELLP syndrome?
HELLP syndrome is a serious complication in preeclampsia, where it presents as hemolysis, elevated liver enzymes, and low platelet count.
Yes. So as HELLP syndrome is a very serious aspect of pregnancy-induced hypertension, it is very important to know its clinical features. So what are the clinical features of HELLP syndrome?
One patient might present with any of the following symptoms, such as epigastric pain, nausea, vomiting, jaundice, and increase in the abdominal circumference.
Yes, very rightly said. And what are the diagnostic criteria of HELLP syndrome?
The diagnostic criteria is hemolysis, ma'am, which is a crucial hallmark of the HELLP syndrome, where we can see abnormal peripheral blood smear and increased bilirubin, which is greater than 1.2 milligram per deciliter. And also there is elevation in elevated liver enzymes such as aspartate aminotransferase, which is greater than 70 international units per liter, and also increase in the lactose dehydrogenase, which is greater than 600 international units per liter. As well as we can also see thrombocytopenia, where the platelet count is less than 1 lakh per millimeter cube, or there is decreasing in the trend of platelet count on the lab investigations.
Are there any other conditions which mimic HELLP syndrome? Like, what are the differential diagnoses of HELLP syndrome?
Yes, ma'am. Differential diagnoses are acute fatty liver of pregnancy, appendicitis, cholestasis of pregnancy, or hepatic encephalopathy.
Yes, very good, Pratyusha. If such patient comes to you, now the case you have mentioned, which lab investigations would you like to advise to this patient?
I would like to advise for hemoglobin and hematocrit, ma'am, where we can see for hemo concentration, which is supportive diagnosis of preeclampsia, and it is also an indicator of severity. And if these values decreases, then one can suspect for hemolysis. And thrombocytopenia, where the platelet count decreases less than 1 lakh per millimeter cube, or there is decreasing in the trend of platelet count. And there is also presence of proteinuria upon urine protein is to creatinine ratio and increase in the serum creatinine levels, as well as increase in the serum aminotransferase level. I would also like to see for the patient serum magnesium, blood sugar level, and glycosylated hemoglobin.
Why would you advise serum magnesium level in this patient?
Ma'am, most of the preeclamptic patients would be on magnesium sulfate therapy, and one should put a careful watch on the serum magnesium level. And we should know the normal levels of serum magnesium, and also we should avoid the toxicity of the magnesium.
Yes. And why have you advised blood sugar level and HbA1c?
My patient is a known case of gestational diabetes mellitus. So, ma'am, I would like to see her blood sugar level and glycosylated hemoglobin.
Yes, and glycosylated hemoglobin level will tell you about the control over last 3 months of blood sugar level in this patient, right?
Yes.
Okay. So what is significance of platelet count from an anesthetist point of view?
Ma'am, platelet count, if it is less than 50,000 per millimeter cube, and I would like to change my plan of anesthesia, I would prefer to give general anesthesia in such patients. And if platelet count is 50,000 to 80,000 per millimeter cube, we have to see the patient risk and benefit factors and plan further according to the patient. And if platelet count is more than 80,000, then we would go with neuraxial anesthesia.
Yes, and at what platelet count there is very high risk of intraoperative bleeding?
Ma'am, platelet count, if it is less than 40,000,
40 to 50,000.
Yes, ma'am, 40 to 50,000, there is risk of intraoperative bleeding. And in such patients, I would like to advise for pooled random donor platelets administration.
So at this level of platelet count of less than 40,000, you will give platelet transfusion,
Yes,
right?
ma'am. Yes, ma'am.
Okay. Can HELP syndrome be a surgical emergency?
Yes, ma'am. If the patient presents with subcapsular hematoma, rupture, then it leads to internal bleeding, and therefore patient might land up in hypotension and shock.
Yes, that's why HELP syndrome, it is very essential to know its diagnostic criteria, its clinical features, because it ultimately changes your further management, right?
Yes, ma'am.
Okay. Would you like to advise the other coagulation profile tests like activated partial thromboplastin time or prothrombin time in this patient?
Ma'am, it is not mandatory to advise for every patient, ma'am. I wouldn't advise in my patient because her platelet count is more than 1 lakh per millimeter cube.
Yes. So if there is decreasing trend of platelet count of less than 1 lakh, patient is giving history of bleeding disorder, you suspect any bleeding disorder, you will go for further coagulation profile.
Yes, ma'am.
Okay. Very good. So what are maternal comorbidities which are associated with HELP syndrome?
Maternal comorbidities would be disseminated intravascular coagulopathy, pulmonary edema, acute respiratory distress syndrome, acute renal injury, or liver hemorrhage or liver failure, sepsis, shock, and death.
Yes. Okay, Pratyusha, will you tell me, are proteinuria and hypertension are essential features to diagnose HELP syndrome?
No, ma'am. Proteinuria and hypertension are not essential features to diagnose HELP syndrome because there's an incidence of 12 to 13%. Only 12 to 13% of patients shows it.
So 12 to 13% of the patients who are having HELP syndrome are normotensive, or in those patients, proteinuria is absent.
Yes, ma'am.
Right?
Yes, ma'am.
Okay. If your patient is having epidural catheter in situ, you are given liver analgesia, at what platelet count you would like to have for removal of epidural catheter?
Ma'am, I would prefer for 75 to 80,000 per millimeter cube, ma'am.
Right. Yeah, very nice. Should we go for further question?
Yes.
So this is one more question for our audience. Concentration of following clotting factor increases during pregnancy except factor 10, factor 2, factor 8, and factor 13. I would like to request Dr. Sanklecha Madam to take over the case.
Ma'am, we have to give audience for 5-10 seconds, and we can discuss the questions there, only responses.
Okay, we'll do that. Yeah.
Yeah, two responses we have here is D, option D. Most of people are like going with D. Back to 13, most of the people are. Yes.
We have not discussed the previous questions also.
Yeah, yes, ma'am.
So should we go to previous questions?
Yes.
So what are the answers?
For this question, there is a mixed response. So people have marked D, C, and B. So I think they have confusion in this question.
Actually, answer is C, because we will find glycosuria, proteinuria, and bacteriuria in such a patients.
These are the normal findings, no?
So how many given the answer C?
Only one has answered C, sir. Many have answered D and B. So only one response is C.
So these are the normal finding in urine examination in normal pregnancy.
So hematuria is the correct answer. So should we proceed, Dr. Seema?
Yes, ma'am.
So this is discussed.
This has most of the responses go with D for this question, clotting factors.
The answer for this question is factor 2, option B.
Factor 2.
Okay, Dr. Seema, should we go ahead?
Yes, ma'am. Yes.
So Dr. Vaishnavi and Dr. Pratyusha, till now we have discussed what are the effects of PIH on various organs, their pathophysiology and their complications. So in your patient, how will you manage or optimize your patient before you intervene?
First we will optimize hypertension, ma'am. As patient is already taking antihypertensive, that is tablet labetalol 100 milligram twice a day. Despite of taking antihypertensives, patient's blood pressure is not controlled. So I will communicate with treating obstetrician and increase her labetalol dose, and also I can give oral nifedipine 10 milligram 10 milligram 8 hourly to the patient, and simultaneously I will monitor her blood pressure.
Yes. So dual antihypertensives you can use for better management of hypertension. Okay.
Yes, ma'am. Then I will give her seizure prophylaxis. If pregnancy is less than 34 weeks, then I will give her steroid therapy. And we will wait for 24 to 48 hours, and then we will proceed to termination of pregnancy.
What is the seizure prophylaxis? How it is given?
Seizure prophylaxis, for seizure prophylaxis, we will give magnesium sulfate. There are various regimens for giving this Maxel therapy. We usually follow pre-chart regimen. In that regimen, loading dose of magnesium sulfate 4 to 6 gram IV over the period of 15 to 20 minutes we will give. Then 5 grams magnesium sulfate intramuscularly on each buttocks. So total dose of 14 gram we will give as loading dose, and then we will maintain 5 grams magnesium with 5 gram magnesium sulfate in alternate buttocks for hourly.
Okay, so once you are given loading dose of magnesium sulfate, it is mandatory to monitor the patient very closely. Like you said, you will monitor urine output, deep tendon reflex, and respiration. So can you tell me what are the normal levels of magnesium?
Normal levels of magnesium is 1.7 to 2.4 milligram per deciliter.
Yeah, and therapeutic range is 4.8 to 8.4.
2.4.
So above these levels, you should be very, very careful when magnesium sulfate is given. What are the toxic levels? We have already mentioned.
Yes,
So,
ma'am. If
more
it
than
more
yeah,
than 10 milligram per deciliters, then there is loss of patellar reflex we can see. If there is more than 50 milligram per dl, then respiratory paralysis can occur. If it is more than 25 milligram per dl, patient may land up in cardiac arrest.
yeah. So if the toxic levels you can observe, then first you will start with oxygenation of the patient and you will think of antidote. So which antidote you will use?
We will use 1 gram of 10% calcium gluconate over the period of 10 minutes. Intravenously we can give.
You can always remember that is the largest ampoule in your operation theatre. It is the only 10 ml ampoule in your route. So you will not, forget.
Yes.
If calcium gluconate is not there, which drug you will use?
Calcium chloride I can use.
Can be used. Okay. Uh, Fine. So how will you manage acute severe hypertension in preeclampsia? Medical management.
Ma'am, medical management could be we can start patient with labetalol, ma'am, where the onset of action is from 5 to 10 minutes, and the starting dose which we can give is 20 milligram IV, and then we can increase every 10 minutes to 40 to 80 milligram, and the maximum dose which we can give is 220 milligram IV. And hydralazine, its onset of action is 10 to 20 minutes. We can start with 5 mg IV, and every 20 minutes we increase the dose to the maximum of 20 milligram IV. And nifedipine, onset of action is 10 to 20 minutes, and we can give this tablet 10 mg per orally, and every 20 minutes we can increase the dose to the maximum of 50 mg. And nicardipine, its onset of action is 10 to 15 minutes, and we can start it as like initial infusion of 5 milligram per hour, increasing by 2.5 milligram per hour every 5 minutes to the maximum dose of 15 milligram per hour.
Yeah. So in books it is mentioned that we use alpha methyl dopamine or that is the best drug. Actually, it is a best drug, but is it available in India?
No, ma'am.
So now obstetricians are saying that it will be available in next 5-6 months. But till now, we are using labetalol and nifedipine. So if it is not controlled with labetalol, maximum how much maximum labetalol we can give in 24 hours?
2,400 milligrams.
Yeah, and if still it is not controlled, then multimodal like labetalol and nifedipine combination usually it is used. And you must know all these medications before you take the patient for LACS, because when you take this patient for LACS, you must be knowing that what was the last dose and how much it was received by the patient.
Yes.
Because if you are thinking of giving spinal anesthesia to the patient, isn't it?
Yes, ma'am.
Okay. So very good, Pratyusha and Vaishnavi. We'll move to one more question in quiz time. Yeah. What is the loading dose of magnesium sulfate for seizure prophylaxis in severe preeclampsia? 1 to 2 gram, 2 to 4 gram, 4 to 6 gram, 6 to 8 gram. So write down correct answer in chat box. Dr. Shima, should we wait and take the answers and then proceed?
Yes, ma'am. Just 5 seconds.
Okay.
They're all giving the response C.
Yeah.
Everybody is with C.
Yes, that is the correct answer.
Yes.
Thank you. Now I request Dr. Jayashree to proceed with the test results.
Thank you, madam. Vaishnavi and Pratyusha, can you tell me the complications which you expect in a patient of severe PIH?
Yes, ma'am. As PIH can affect both mother and fetus, there are maternal complications and fetal complications can occur. Maternal complications like HELLP syndrome, disseminated intravascular coagulation, intracranial hemorrhage, cerebrovascular accident, congestive heart failure, pulmonary edema, placental abruption, acute renal failure, liver rupture, or septic shock can occur. In fetal complications like prematurity with respiratory distress, intrauterine growth retardation, oligohydramnios, intracranial hemorrhage, or meconium aspiration can occur in fetus.
Very good. And can you tell me which set of patients these complications are more?
Early onset preeclampsia, that is preeclampsia before 34 weeks, are more prone to these complications, and also patients who are having pre-pregnancy diseases like hypertension, diabetes mellitus, chronic kidney disease, and thrombophilias.
Okay, correct. Do you know the leading cause of death in severe PIH?
Yes, it is due to stroke, ma'am.
Stroke. What type of stroke is more common?
Hemorrhagic strokes are more common.
What?
Hemorrhagic strokes are more common.
Okay. And what is the percentage of hemorrhagic strokes?
It is approximately 93%.
Okay. And when is it very common?
It is common in immediate postpartum period.
Correct. And what is the percentage of strokes in the postpartum period?
It it is approximately 57%.
52 to 53%. Correct. So, you know about the immediate complication, that is stroke, that is a hemorrhagic stroke. Most commonly, it is associated with thrombocytopenia, right?
Yes.
And how do you decrease the risk of intracranial hemorrhage?
When there is onset of blood pressure more than or equal to 160 by 110 millimeters of mercury, we have to manage this blood pressure within 30 to 60 minutes of its onset.
So, you have to monitor this patient very closely, and you have to keep a strict watch over the blood pressure of the patient. And you shouldn't take more time to control the blood pressure. And this way, you can decrease the risk of intracranial hemorrhage. Correct. Which is a superior predictor of this intracranial hemorrhage? Is it the systolic blood pressure, the diastolic, or the mean arterial pressure?
It is systolic blood pressure.
Systolic blood pressure is more commonly associated with hemorrhagic strokes, right? So, what drug should be avoided in these patients intraoperatively?
Ergot alkaloids like methotrexate should be avoided.
Can you hear me?
Yes, ma'am. Am I
So,
audible, ma'am?
yes, yes. Tell me.
Intraoperatively, ergot alkaloids like methotrexate should be avoided.
Because it increases the risk of hypertensive crisis, right? So, we have discussed about HELP syndrome. We have discussed about the hemorrhagic strokes. So, pulmonary edema is one more complication. And how do you treat pulmonary edema if at all it occurs?
Yes, ma'am. We will oxygenate the patient. Then we will restrict the fluid therapy, and also we can give diuretics like injection furosemide 10 milligram IV.
And which is the most common time when the patient is vulnerable to pulmonary edema?
It is immediate postpartum period, ma'am.
And intraoperatively?
Immediately after delivery of baby.
And the pressure response at the time of intubation, extubation. If there
Yes.
is a pressure response, there can be a hypertensive crisis and you have to be watchful. Okay. So you should take care of the pressure response. Correct. So I think we'll go to the next slide. We have a question for the audience. A preeclamptic patient develops pulmonary edema during cesarean section. What is the most likely cause? A, fluid overload, B, cardiac dysfunction, C, aspiration pneumonia, and D, anaphylaxis. Please put your answers in the chat box.
There is a mixed response. People are choosing between A and B. Like half of them
Yes.
are going for A, half of them are going for B.
A is the correct answer. Fluid overload. Thank you. Over to Dr. Kashinath Zada.
Thank you, madam. As we have discussed PIH in details, now it's time to give anesthesia to our patient. Is it right, Vaishnavi or Pratusha?
Yes, sir.
So can you tell me which is the best plan of anesthesia in such your patient?
Sir, I would prefer to go with neuraxial anesthesia, sir.
Why you choose neuraxial anesthesia?
Sir, because neuraxial anesthesia is safe to both baby and mother, and also it is not contraindicated in my case since the platelet counts are above 1 lakh per millimeter cube.
Okay, so there is no contradiction for neuraxial anesthesia in your patient.
Yes,
Why
sir.
you are not chosen general anesthesia then in your patient?
Sir, general anesthesia is less desirable, sir, and one should always be careful in such patient because there is possibility of difficult tracheal intubation, secondary due to airway edema, and also there is transient but severe hypertension during tracheal intubation and extubation. And such patients are rapid desaturation can occur due to decrease in the FRC and increase in oxygen consumption.
Okay, so right. So general anesthesia is less desirable in such a patients. So now you have given the neuraxial anesthesia to your patient, right?
Yes, sir.
So what are your intraoperative goal in your patient?
Intraoperatively, we should properly we should give oxygenation to the patient. Then we should monitor for hemodynamic stability in the form of blood pressure. Blood pressure should be maintained within plus or minus 20% of its mean arterial pressure. We will give restricted fluid therapy with balanced salt solution at the rate 1 ml per kilogram per hour. Then we will prevent supine hypotension syndrome by left uterine displacement. We will prevent intraoperative hemorrhages by giving adequate uterotonics. That is, we will give injection oxytocin 10 units, 10 international units in 100 ml NS over the period of 10 to 15 minutes. Uh,
Okay, suppose you are given pitocin, but still the uterus is flabby. So will you give any another drug for it?
as my patient is having preeclampsia, so I won't give methergine or carbopros to this patient.
Okay.
And
So then what you will do?
I will repeat the dose of oxytocin, 10 international units. I will give intravenously, and simultaneously I will ask the obstetrician to give uterine massage.
Okay. So what are your next intraoperative goals then?
We are giving neuralgia analgesia. Still, patients may complain of pain during deposition of uterus. So we will give injection fentanyl 1 to 2 microgram per kilogram IV if patient feels any uneasiness during deposition of uterus.
Okay.
For prevention of nausea, vomiting, and shivering, we will give injection dexamethasone 0.15 milligram per kilogram IV.
Okay. So by keeping all your intraoperative goals, you are given this neuraxial anesthesia to your patient. And suppose on the table your patient develops convulsions intraoperatively. So how you will manage that case then?
First, I will give 100% oxygen by Hudson's mask. Then I will insert oropharyngeal airway for prevention of tongue bite. Then I will apply jaw thrust. Also, I will give magnesium sulfate 2 to 4 gram intravenously. Once baby is delivered, I will give injection midazolam 0.01 milligram per kilogram IV.
Okay, very good. So I think now it is time to ask questions to the audience. So in preeclampsia, what is the primary concern with regional anesthesia if platelet count is low? The first option is epidural hematoma. Second is spinal cord injury. Third is inadequate analgesia. Fourth is fetal distress. You can write down your answer in the chat box. And We'll wait for some time for your answers.
We have most responses as A, sir.
Yeah, so actually that is the correct answer. So we are more worried of epidural hematoma. Okay, that's why we need adequate platelet count for such a patients. Now I request Sauni madam to continue further case discussion.
Thank you, sir. Am I audible, Vaishnavi and Sarkisha?
Yes, ma'am.
So as just you said that you will choose neuraxial anesthesia for the patient. Are there any specific indications to give general anesthesia for in this patient, in these patients?
Yes, ma'am. The indications would be if there is presence of severe thrombocytopenia, where the platelet count is less than 50,000 per millimeter cube, and fetal distress with reassuring maternal airway, and if there is any severe ongoing maternal hemorrhage and eclampsia. In such patient, I would prefer to give general anesthesia.
Okay, very nice. As these patients are high-risk patients, are there any specific concerns when you give general anesthesia in these patients?
Yes, ma'am. My concerns would be
Yes, ma'am. As pregnant patients are more prone to difficult airway, so we will keep difficult airway crash cart ready. We will avoid pressure response at the time of intubation by giving drugs. Then we will give, as the patient is already receiving magnesium sulfate for seizure prophylaxis, it could be interact with non-depolarizing muscle relaxant. So we have concern about use of non-depolarizing muscle relaxant. Also, we have concerns about post intraoperative complications like intraoperative hemorrhage, desaturation at the time of intubation, and also we are concerned about hypertensive crisis intraoperatively.
Yes, right. So, Vaishnavi, can you describe the technique of general anesthesia? How will you give general anesthesia to this patient?
Yes, ma'am. First, I will prepare OT I will keep difficult airway crash cart ready. In that, I will keep oropharyngeal airway, laryngeal mask airway, laryngoscopes, McCoy blade, lower size endotracheal tubes, suction catheter, bougie, stellate. I will keep also video laryngoscope. I will keep blood and blood products ready. That is packed RBCs, fresh frozen plasma and platelet. Then emergency drugs. In that I will keep labetalol, ismolol, loxicard, magnesium sulfate, calcium gluconate, furosemide, tranexamic acid.
Yes. Okay.
Then I will take informed consent. I will tell patient about steps of general anesthesia. Also, as we are planning for rapid sequence induction, I will tell patient that she might feel pressure over her throat. Then I will secure IV line with large bore cannula. I will apply monitors for monitoring pulse, for monitoring oxygen saturation, blood pressure, ECG. Uh, then I will start pre-medication. In pre-medication, I will give aspiration prophylaxis. For that, I will give injection ondansetron 0.1 milligram per kilogram IV, injection metoclopramide 10 milligram IV, or injection dexamethasone 0.15 milligram per kilogram IV. Then I will give injection glycopyrrolate 0.004 milligram per kilogram IV as an anti-sialogogue agent. Then I will pre-oxygenate the patient with 100% oxygen by tight fitting mask and ask the patient to take 6 to 8 vital capacity breaths. Then my plan of anesthesia is rapid sequence induction with endotracheal intubation. Then before induction, I will give injection loxicard 1 to 1.5 milligram per kilogram IV for blunting pressure response at the time of intubation. Then I will start with injection propofol 2 to 3 milligram per kilogram IV. Then I will ask to give cricoid pressure. Then I will give injections choline 1.5 to 2 milligram per kilogram IV. Then I will insert cuffed appropriate size endotracheal tube, and once cuff is inflated, I will tell to release precoil pressure. Then I will check for air entry. it- and also I will check for ETCO2 graph. Then
Yes.
I will maintain anesthesia with oxygen, air plus inhalational agents. I will put MAC less than 1. Uh, then I will give non-depolarizing muscle relaxant for maintaining anesthesia. And also intraoperatively, I will give balanced salt solution intravenously. I will give restricted fluid therapy, that is 1 ml per kilogram per hour. Uh, Once baby is delivered, I will give uterotonics for maintaining uterine tone. Then for analgesia, I will give injection fentanyl 1 to 2 microgram per kilogram IV. Once procedure is done, I will extubate the patient in fully awake state.
Yeah, very meticulous planning, Vaishnavi. One more important monitor is urine output. You have to measure urine output intraoperatively. And while giving general anesthesia, also you have to maintain left uterine displacement. Okay, when the gravid uterus is more than 20 weeks, there are high chances of inferior vena cava getting compressed because of gravid uterus. So that hampers venous return and reduces cardiac output. So it is very essential to maintain left uterine displacement while administering general anesthesia. That will prevent precipitous fall of blood pressure. Okay, so it is very important to tell about left uterine displacement. Okay, so now this is intraoperative management. How will you manage this patient post-operatively?
We would like to see post-operatively for her pain. We would like to advise to give injection paracetamol or NaCH or opioids, ma'am. And also fluid restriction should be continued by giving fluid therapy of 1 ml per kg per hour. And one should also put a strict monitoring on blood pressure and blood sugar. And we have to continue antihypertensive medication as per patient's requirement. Since this patient is on magnesium sulfate therapy, we have to continue magnesium sulfate prophylaxis for 24 hours postpartum. And we have to put a careful watch on magnesium toxicity and monitor for serum magnesium levels. And also we have to see for any active bleeding in such patients, and we have to put a watch on Taylor and platelet count.
Yes, very rightly said. And Vaishnavi, as you mentioned, intraoperatively, there can be interaction between magnesium sulfate and non-depolarizing muscle relaxant. So you can also monitor train of flow so that you can know the dose and time of administration of non-depolarizing muscle relaxant. Very well answered. Can we take the MCQ? Yes, the next question for our participants. In a preeclamptic patient, what is the primary mechanism of magnesium sulfate-induced neuromuscular blockade? A. Presynaptic acetylcholine depletion. B. Postsynaptic nicotinic receptor antagonism. C. Calcium channel blockade. And D. Sodium channel blockade. Are we getting responses?
Yes, ma'am. A and C mixed responses.
C.
A and C.
A and B. Okay.
A and C, ma'am.
A and C. Okay.
C is mostly there. Voted for
Yes.
one
So
response
the
is C also.
okay. So the right answer is C. Calcium channel blockade. It is not presynaptic acetylcholine depletion, but it prevents presynaptic acetylcholine release. That's why the answer is C.
C.
Now I will request Dr. Kashinath Zadeh sir to take over the case.
Thank you, madam. As we have said, your patient is having PIH associated with gestational diabetes mellitus, right? So,
Yes, sir.
Pratisha, can you tell me what is the diagnostic criteria for gestational diabetes mellitus?
Yes, sir. According to American Diagnostic Association, we screen for oral glucose tolerance test during the 24 to 28 weeks of gestational age. And if the mother is said to be gestational diabetes mellitus, if any of the following values have reached, that is fasting fasting level of 92 milligram per deciliter, 1 hour level, 1 hour postprandial glucose plasma glucose level of more than 180 milligram per deciliter, or 2 hours postprandial plasma glucose level of 153 milligram per deciliter.
Okay, correct. Is the same criteria used in non-pregnant patients also?
No, sir.
So which is that criteria then?
So according to World Health Organization, in non-pregnant women, the diabetes mellitus criteria would be fasting plasma glucose level of more than 126 milligram per deciliter, or 2 hour postprandial plasma glucose level of more than 200 milligram per deciliter.
Okay, right. So can you describe me the pathophysiology of gestational diabetes mellitus?
Yes, sir. Since the hormones in pregnant as the pregnancy proceeds, the hormones, fetoplacental hormones such as cortisol, prolactin, progesterone, and estrogen. This causes increase in the insulin release, and for compensatory mechanism, pancreas releases the increase in the insulin secretion. And if this compensatory mechanism goes well, then it will cause normal pregnancy. And if there is any disturbance such as delay or insufficient insulin secretion by pancreas, then the mother may land up in gestational diabetes mellitus.
Okay, rightly said. Pregnancy is a state of increased insulin resistance. And whenever there is any insufficiency in creating that compensatory increase in insulin secretion, patient may land up into the gestational diabetes mellitus, right? Okay.
Yes.
So can you tell me any complications associated with gestational diabetes mellitus?
Complications of gestational diabetes is both to the mother and the baby. Primarily to the mother, there is increased risk of preeclampsia, polyhydramnios, and there could be difficulty in the operative delivery, diabetes mellitus later in life, and past history of gestational diabetes mellitus can lead to hypertension, hyperlipidemia, and ECG abnormalities. And risk to the baby is there could be increased risk of perinatal mortality and morbidity, large for gestational age, neonatal hypoglycemia, neurodevelopmental delay, obesity, and diabetes in later life.
Okay, right. Now, if such patient is for operation,
Sir?
if you need to
Sir,
give
you are not
anesthesia.
audible, sir.
Hello. 1 minute. I am audible?
Yes, sir.
So now such patient is for surgery. So what will be your anesthesia concerns in that case then?
As an anesthetist, we should be very careful first in monitoring perioperative glycemic control and hemodynamic stability. We have to avoid hypotension in such patients, and one should also be careful during intubation, because there is a possibility of difficult intubation, because there is collagen cross linkage in the cervical segments, which will lead to difficulty in the extension or flexion of the neck. And there is also delayed gastric emptying. So fasting hours would be 10 to 12 hours. Even though she has consumed food 6 hours or 8 hours priorly, I would suggest for fasting hours to be 10 to 12 hours. And the risk of infection is more in diabetic patients. And also one should put a careful watch on fetal hypoglycemia.
Okay. So actually these patients are more prone for autonomic neuropathy. So you will always, there is concern about hemodynamic stability in such a patients. They are more prone for hypotension also. And
Yes.
as there is a risk of infection, you will try to give broad spectrum antibiotic before starting your case. Okay.
Yes. Yes.
So now I think it's time for asking question to the audience. So the question is, what is the preferred screening method for diagnosing gestational diabetes mellitus in pregnant women? The options are glycosylated hemoglobin, fasting blood glucose, oral glucose tolerance test, and random plasma glucose test. So you can write down your answer in the chat box. Okay. Have you got the responses?
Yes, sir, we are getting responses. They are answering C.
Yes, that is the correct answer. Oral glucose tolerance test is the preferred screening method for diagnosing gestational diabetes mellitus. Now I ask Dr. Jayashree Madam to take further questions.
Thank you, sir. Pratyusha and Vaishnavi, your patient is a case of mild anemia. Can you tell me the pathophysiology of anemia in pregnancy?
Yes, ma'am. In pregnancy, there is a plasma volume expansion begins at 6th week of gestation. Plasma volume expansion is there is 50% increase in plasma volume, but there is only 30% increase in RBC volume. As plasma volume expansion is much more than RBC volume expansion, then hemodilution can occur and it will lead to the physiological anemia in pregnancy. Uh, this shows
What are the positive effects of this?
it shows improved placental perfusion, decrease in blood viscosity. It protects against blood loss and at delivery. It prevents blood stasis and placental thrombosis, and it also improves oxygen delivery to the fetus.
Okay, very good. Are there any complications of anemia in pregnancy?
Yes. Complications of anemia during pregnancy are increased risk of postpartum hemorrhage, heart failure, puerperal sepsis, poor wound healing, or transfusion-related morbidity.
Okay, good. So I think we have the question for the audience. Yes. The sensitive test to detect iron deficiency anemia during pregnancy is A. Serum iron, B. Serum ferritin, C. Serum iron binding capacity, and D. Serum transferrin. I request the audience to put the answers in the chat box. We have B and C as your responses. So the correct answer is B, that is serum ferritin. Thank you, audience, for your patient listening and your active participation. I request Sanklecha madam to take over for the rapid fire.
Okay. Very good presentation by Vaishnavi and Pratyusha. And for audience, we have arranged, not only for audience, for our presenters also, we have arranged rapid fire question and answer series so that we can just recapitulate what are the important points in this case presentation. So should I start? Are you ready?
Yes, ma'am.
So what is the maximum dose of labetalol used in 24 hours in patients with preeclampsia?
It is 2400 milligrams per day.
Correct. What is Press syndrome?
Ma'am, Press syndrome is posterior reversible leukoencephalopathy syndrome.
Yeah, it's a reversible condition. What is the maximum dose of magnesium sulfate that can be given 24 hours in preeclampsia?
30 gram.
Yes, repeat.
30 gram.
Yes, correct. Which anesthetic agent can worsen glucose tolerance in patients with GDM?
It's sevoflurane, ma'am.
Okay. Which anesthetic drug never crosses placenta?
Non-depolarizing muscle agent and depolarizing muscle agents.
Yes, correct. What is neurological markers for CNS manifestation in PIH?
It is optic nerve sheath diameter and also regional cerebral vascular oxygen hemoglobin saturation.
Yes, so you have to do otoscopy in these patients. In RSI, what is the amount of force needed for cricoid pressure?
Ma'am, initially we put a pressure of 10 newtons. Once the patient is in deep plane of anesthesia, we would further increase the pressure from 20 to 30 newtons.
Correct. What is the cardiac output maximum during pregnancy?
It's in immediate postpartum period.
Yes, right. What is the bolus dose of lipid emulsion in last?
Ma'am, it is 1.5 ml per kg, ma'am, initial dose, and the bolus dose we give is 0.25 to 0.5 ml per kg per minute.
Yes. So intralipid should be always available in operation theaters. Yes, thank you so much and very well answered, Dr. Pratyusha and Dr. Vaishnavi.
Thank you, ma'am.
Dr. Shima, what is the plan now? Questions asked by audience?
Yes, ma'am, we have a lot of questions.
Yes.
So,
I request all the faculty members to unmute so that we all can answer, those who are like better in answering that question. Yeah. So We will take questions one by one. First, we'll ask our students. If they are not able to answer, then we will answer the question. Sir, is that okay? Madhuri madam, is that okay?
Yes, madam. Please proceed.
Yeah.
Yes, ma'am. One of the questions is, patient is a known seizure disorder and already on anti-seizure medications. She presents with severe preeclampsia. Should there be any dose modification for magnesium sulfate or pre-existing anti-seizure medications?
Vaishnavi?
Yes, ma'am. We will continue magnesium sulfate intraoperatively. We will continue magnesium sulfate till 24 hours post-operatively. Also, additionally, we can give injection midazolam of 0.01 milligram
No,
per
the
kilogram.
question is different. They are asking whether we should continue with antileptic and magnesium sulfate as well. Is there any dose modification? I think we should we always continue with anti-epileptic agents, and before we intervene or before we take the patient for surgery, we give bonus dose of anti-epileptic, and even if she is a known case of preeclampsia, we will continue giving her magnesium sulfate as a seizure prophylaxis.
So, ma'am, shall I add something here?
Yes, sir.
See, this is a very good question actually, if you
Yeah.
take into the depth of this question.
Yes, sir.
Now, the patient already having now the fourth comorbidity.
Yes.
They are presenting the three comorbidities. This is the fourth one. That means the history of epilepsy is there. Already on the anti-epileptics. If the patient is on anti-epileptics, he is more prone to seizures, more
Yes.
prone to convulsions in the PIH case. Here, the most important part is the plasma level of the drugs. So, it's always prudent to have a good plasma levels. The dose should be continued in the same manner it has been continued without even the pregnancy. So the anti-epileptic medication should never stop
Yes.
unless and until you have a fasting status to be ensured for a section. I think maximum 4 hours gap is good enough, but as soon as you become, after the section, even after 4 hours of the section, you continue with the anti-epileptic. That is the one thing. Second part is the dose of magnesium sulfate in such cases. There is no, synergistic effect. You can't have a synergistic effect that the dose of magnesium sulfate should be modified or titrated according to the dose of anti-epileptics. The mechanisms are entirely different. The pathology is entirely different, but the end result is same, the hyperexcitability of the neural networks. So in these cases, it's always prudent. The way we have always choose the magnesium sulfate according to the body weight, according to the clinical situation, that should continue as a prophylactic measure for PIH. And the anti-epileptic dose has to be continued in the same manner, so that we should not take any risk for the sake of experimentation or sake for judging that dose may be depressing the fetus or something like that. So that is the ideal way to go for such cases.
So may I add something?
Yeah, please, madam, please.
Usually in our institution, we give 1 hour before the surgery loading dose of anti-epileptic, and immediately after delivery of baby, we give midazolam in addition. And always we support the patient with oxygen supplementation. I think these precautions we take.
Yeah,
And
that
we
is always
continue with magnesium sulfate even postpartum.
These are important because you should not give any sign of any panic or anxiety to the patient in this case.
Yes.
Dr. Shobha, you have raised the hand. You want to add to this thing, or you want to add something new?
I want to ask that I received a patient unregistered, without any investigation, and she was 19 years old, husband was 21 years, and she convulsed at home, and she came convulsing to our institute. So we did not know anything about her NVM status. All her reports were not, because she was never investigated. She straightway came convulsing to the operation theater. So what the obstetrician had already 14 grams of magnesium sulfate by 10 grams on both the buttocks and 4 grams IV. So should we go about this case? Like, there was no time for investigation.
If we get such type of patient unregistered you don't know the status of, her whatever food or fluid she has taken. I would say that though she's convulsing and obstetrician is directly taking her to operation theater, it's not that urgent. You can take some time because now mother is more important than fetus. Okay, so you will take all the precautions like aspiration,
She has
prophylaxis.
abruption. Along with that, she was bleeding too.
If it is abruption, then you should go directly for general anesthesia with RSI, and you have to take the risk. Already Maxelf is given, and once the baby is out, then you can continue giving her Maxelf, Midazolam, and all the other anticonvulsants.
Can we actually, in such patients, madam, will it be good to use thiopentone as an induction agent, as it reduces
Yeah, if it is available, definitely we can use it, but availability is a problem nowadays. That's why we choose propofol.
Thiopentone, ma'am, is it easily available on your trolley nowadays?
It is available if we want to use it.
It is available.
It's available, but because of popularity of propofol and more of atomitate, so we are having just diminishing levels of thiopentone on the trolleys nowadays. But it's always a good drug to have in case of such cases.
Yes.
So we had a hard time that the uterus wasn't contracting. Like she had an abruption, the baby was already dead. So we were not worried about the baby. But then PPH sort of, I mean, she was bleeding and the uterus was atonic on the table. We gave her carbitocin. I think that's a better drug than pitocin. We gave her carbitocin. We started with the pitocin drip. Then carboprost, like prostaglandin, was again given, and they are asked to inject carboprost. So, how much is the dose for carboprost? We can go.
Madam, I differ with this. Usually, you should use only oxytocin in such cases because if once you give carbopras, then further action of oxytocin will not be there because all the oxytocin receptors are blocked. So it is, if I would have been there, I think we should go with oxytocin, maybe 20 international units by say in 100 ml of NS you should give. And if it is still not responding, then you should give bolus dose of 5 international units. And you should tell your obstetrician to give bimanual massage and other methods like whatever beans and all these things they can perform. But once you give prostodone or you can, if you give carboprus, we have seen that then in postoperative period, there is a mess because then uterus does not, if there is again a atony, then uterus will not contract and they will end up in, say, managing with operative procedure like internal iliac ligation they do and all these things.
Absolutely.
And these patients are, because of Maxwell, they are always sedated, means they are drowsy. Of course, she was drowsy, maybe due to post-distal phase or maybe because of calcium. So even after extubation, she was drowsy. So they're constantly asking, is there intracranial? Then we did her ONSD on the table to know the intracranial, raised intracranial tension. But that was normal. Then finally, we advise them to consult neurophysician and then give on the table mannitol to reduce this drowsiness. And we had, since our BSL was normal, we had given a 25% dextrose to reduce the cerebral edema, mannitol to reduce the dexamethasone, like a steroid, to reduce the cerebral edema. But her hemoglobin was quite less, like 6.5. As you said, there was anemia also along with that. She had no GDM, anemia with eclampsia. So we could manage with the 2 PCVs and 8 FFPs, and finally she was all right today. Like, this was an yesterday.
Yeah, madam, actually all the cases, you can't always say customize the thing immediately for every patient. It's an individual approach. Patient may coming up with a variable comorbidities, landing up in the section and giving you a different picture. You can't have a same set of rules and treatment for such patient. You always have to see individually what pathology is really, how much the degree severity. And here, then definitely the scores are going to make you more comfortable to go for a treatment in such cases. And multidisciplinary approach is always better. Even in the obstetrician, the neurophysician, if they are available with you, it's your good luck. And in cases where say carbotocin or prostaglandin questions are being asked, what is to be done, whether to be used together or not. But in such cases, if the uterus is not responding to either of them, because life saving is more important than our, particular this one liking for a particular drug or because of the blood pressures or something like that. If that is the case, you can go for hysterectomy if already the two kids are there. Don't
Yeah.
spare time because uterus is not going to save the lady, but the hysterectomy definitely going to save that maternal. So maternal mortality and morbidity is the foremost thing when such situation arises. So don't consider that what drug regime are being prescribed or being recommended in the national or international literature.
Yeah.
It is always the maternal safety that is the paramount when you are dealing in such situations. Don't go with the just balancing the drugs. Obstetrician is the best person to tell you how he or she feels at that particular moment, what is the status of uterus. So it's not anesthesiologist alone, it's a teamwork here to save the
Yes,
mother.
correctly said.
Next
Thank you.
question.
Yes. Dr. Shima, can we take questions from chat
Yeah,
box? There are
that's
many
important.
questions.
Now we have a question. Is it okay to give steroids in gestational diabetes mellitus?
Yeah, I will answer this question. Actually, steroids, as we know, it causes the hyperglycemia. Okay, but we should check for the risk-benefit ratio. And if there is a risk of preterm birth, it is recommended to give steroids. But if there is no risk of preterm birth, we can avoid giving steroids in such a patient.
We are giving only just two doses of steroids.
Yeah.
It is 8 milligram, say 12 hours apart. So I don't think that is a very the rise of the sugar is just for a while, so that we can manage. But lung maturity of baby is more important, so that mother will save its NICU admission. So we should always think of risk benefit ratio.
And ma'am, small doses of steroids are not going to cause much
Yeah.
damage to your glycemic status or to the fetus also. Because these are the long-standing gestational diabetes, the mechanism is different. In the real established diabetes is a different thing. And the steroids have just a momentary role. They are not going to cause a chronic hyperglycemia, not going to suppress the insulin secretion to that extent that they are going to cause harm to the mother. But definitely a very good profile for the fetus to survive in these circumstances. Shima, next question you can ask.
Yes, sir. There's a patient for emergency LSCS, eclamptic. She has hematuria also. And she has asked, Dr. Pooja has asked, is BTCT reliable in absence of labs? If we don't have labs, is BTCT reliable in case of emergency LSCS, preeclamptic patient with hematuria?
I will answer this question. Actually, nowadays, don't do BTCT. The role is quite limited. I think if it is a real emergency, as you don't have time to do even CBC, I don't think so. At least you can get CBC, and that is the most important thing. If I know CBC, I go ahead with the section because that will give me idea about like thrombocytopenia and hemoglobin levels. With that also, we can proceed with the case. But I don't think BTCT is playing any role nowadays. I think Dr. Bajwa will enlighten on this.
Yeah, ma'am, just I will ask one thing. Have in their last 3 decades of practice of anybody here, senior, have you ever seen a deranged BTCT in your life?
I have
Anybody?
not.
So this is an obsolete investigation if you follow the pattern of the BTCT reports in the life. We have got so many good, when you're taking such patients, whether going for the bleeding tendencies or hematuria, that means the coagulation profile is already deranged. Whether it's a vitamin K dependent or it's a vitamin K independent factors which are less, which you may not be able to get report immediately. Patient landing with a fetal distress, absorption or hematuria, so many things are there. The ideal thing is if you have got a blood with you. If you've got a blood with you, you arrange the blood immediately. That's the only thing we can save the life of both mother and fetus. Unless whether you go for the coagulation profile or whether you go for the thromboelastography or those platelet counts, platelet functional count, whatever it is, quality and quantitative estimation, those are going to take time. in such situation, it's always better to go for the operative procedure. If you are thinking that you may have got a spinal recurrent bleed, you go for the GA. But have also be prepared for the difficult airway in such cases. We always have a difficult airway in the parturients. So this is a high risk profile cases. And if possible, in a practical manner, in the practice, you should have a second anesthesiologist on call to help you out. But in institution, if the third year PG or a senior resident is taking the case, they should always inform the consultant that any help is required at any stage. Because these are the cases which are going to throw challenge and put you in some dilemma how to go about it further.
So can I say something?
Yeah, ma'am, please add.
Yeah, actually, the major disadvantage of BTCT is the BTCT get deranged only if there is significant fall in clotting factor. So as in the case, already it is mentioned that hematuria is there. We already know that the patient has some factor of coagulation profile disorder, and as it is an emergency case. So I think the answer lies in the question itself. So we can proceed ahead with the definitely BTCT to give result. There has to be a very significant fall in the clotting factor. So in the early stage, it won't tell you anything.
Yeah, the compensatory mechanism in human body to 50% easily, you can tolerate the compensation of the clotting factor. But I think go with emergency and arrange blood. That's very important.
Yeah, blood component should be radiant.
Yeah.
Ma'am, we have questions related to carbetocin and oxytocin doses. One of the question is, what's
I think
the
we
role
have already discussed oxytocin and carbetocin.
Ma'am, they have asked what's the maximum dose of oxytocin that can be administered intra-op in PIH patients?
I think it is 40
oxytocin-
international units. The maximum dose. I think it is 40 international units, the maximum dose. But I need to confirm with Bajwa sir also.
Actually, at a time, we can do 20 international units and we can repeat increase further 5 to 10 international units, because you should be very watchful while giving oxytocin, because it is again going to cause tachycardia and patient will have some nausea, vomiting and headache also. So, because it has to act with 20 international units. If it is not acting, then you have to add up something.
Top up the dose.
Yes.
Yeah.
That's what is. Actually, even somebody asked that question, I think 10 years back also. What is the minimal dose, not a maximum, minimal dose of oxytocin to be, helpful? The minimal dose is maybe 0 unit. Because many deliveries used to occur and the uterus going to contract and retract even without oxytocin administration from the in vitro or outside from the injection site. And in some patient may go for 5 units, somewhere 10 units and 15, 20 units. Basically, the practice is of going to 15 to 20 international units. And as Dr. Sunita ma'am said, when you have already given 20 international units, almost 90% of the receptors are occupied with the oxytocin. You keep on increasing the dose, it is going to have a ceiling effect. It is not going to impact much of the, the uterine receptors for contraction and retraction. In such cases, it's always prudent to add other drug which may have another mechanism. Maybe you go for methylargometrin, which is, I think, sometimes relatively contraindicated in the PIH cases. But again, the carboprost, misoprostol, so many drugs are available nowadays, and keeping a drug over this one under the tongue, or you can keeping under the vaginal pessary or even in the anal pessary, always have the effect of those drugs, which can be easily taking away the care of uterus. So it's not that we have to go maximum dose of oxytocin. It is a very unethical to develop a study also to find out the maximum dose of oxytocin where it can have a positive effect on the uterine contractions. In such cases, it's not recommended to go for higher doses of oxytocin when the PIH is there and the gestational diabetes is there. And moreover, in anemia cases, the protein binding is so much altered. You are going to give a higher dose of oxytocin and it is going to have a toxic effect also. Cardiac tissue is definitely going to be compromised in presence of anemia. So always be prudent in using the doses. If it's not happening, I think better to switch to the other drugs, not to just relying upon the oxytocin.
Yes.
Ma'am, we have another question. What's the role of NTG in the management of hypertension in these cases? Nitroglycerin.
Genuine answer.
NTG can be used in these patients, but as we have other drugs also to reduce the hypertensive response in these patients, as we discussed in the case discussion as itself, with very specific indication for NTG, if it is a cardiogenic pulmonary edema, then NTG helps the most. As it is an arterial dilator, the very specific indication is cardiogenic pulmonary edema. In such cases, we can use NTG. But for that, to use NTG, you have to have time-to-time blood pressure monitoring because the action is very rapid. So if you have invasive monitoring like arterial blood pressure or invasive blood pressure, it is safe to use NTG. But the specific indication is cardiogenic pulmonary edema.
Can I add something?
Yes.
Actually, NTG is a very short-acting drug, and so it will cause immediate rebound hypertension also. So it will not going to help unless you continue it, and that's why it is not useful most of the times.
And again,
And
it will cause
add to that,
tachycardia also. That is sometimes
and to add to that, shall I add,
dangerous
ma'am?
in
Further?
PIH
Yes, sir.
patients.
NTG is actually venodilator basically, and arterial dilator, hydralazine, and all those type of drugs. And as Dr. Kashinath said, is rebound hypertension mechanism is very, very difficult to control, especially in these cases. And the definitive control of a PIH in these cases is the delivery itself.
Yes, right.
The time that delivery occurs, all the hypertensive receptors, they regress like anything. You get such a good control that even the convulsive methodology has also been regressed, and the hypertensive episode also get to a regression. So in these cases, nitroglycerin, it doesn't have, that much advantage. You may use it. You can use so many drugs. As you mentioned, there are so many drugs available for antihypertensive action in these type of a patient. The most important is the magnesium sulfate itself. When you control the pathology of PIH, even the hypertension is also reduced in such cases. So NTG has almost can say average effect in these type of patients, not that much typical where the cardiac patients are involved.
So another question we have differences between calcium gluconate and calcium carbonate.
Calcium carbonate?
I think chloride.
Chloride.
Calcium chloride.
Oh, chloride, yes.
I think everybody must be reaching that Merino. Now, if you go through the Merino ICU book, it's always written 3 times the amount of calcium present in the calcium chloride. But that is also sometimes can be toxic. If you inject the calcium chloride in such a fast manner, it can have a detrimental effect on the cardiac tissue. It may be more than 3 times more potent than the calcium gluconate. But the idea is the speed of the injection is very, very important. How you maintain the calcium levels in these type of patients, and what type of the deficiency is there. That is also important.
I would like to add one thing, sir.
Yeah, please.
Calcium gluconate it has less tissue necrosis as compared to calcium chloride.
Yeah.
Comparatively,
Definitely.
so it
and
is
should
preferred.
be ideally should be given through the larger veins, the calcium chloride.
So we have a question: should fundoscopy be done in severe PIH patients? Fundoscopy.
I think an obstetrician is sitting beside me. Can I ask the question same to her? My wife is sitting just next to me. Can I ask the same question to her? Hey, anyway, yeah, somebody should answer. I'm just joking around for that question.
Yes, sir. We must do that.
Chest pain. There's a very good question coming up. But I think it's in the uterus or the delivery. It's a delivery section. That question pertains to?
So after delivery.
No, normal vaginal delivery or after cesarean section? Cesarean section already uterus is open.
Repeat the question.
And the question is, why do a lot of patients complain of chest pain after delivery in spite of no methosion?
It is usually
Cesarean section.
observed after cesarean section, not after.
Madam, your voice is low.
Hello, I'm audible? No. No, madam, you're not audible. Am I audible?
Yeah, better,
Yes.
better.
Yeah. So usually this pain is after cesarean section, and when the obstetrician is putting or repositioning the uterus, it is not observed after normal delivery.
I'm not able to hear properly what you just said, ma'am.
Sir, we usually observe this after cesarean section when obstetrician is repositioning the uterus and putting inside.
Yeah, chest pain can be
It's
of
not
many
seen
factors.
after.
Ma'am, it's always coincides with that. When you inject the oxytocin is usually whether you're delivering after just delivery, when you other take sometimes people take out the uterus from outside or somebody, I think, putting the swabs inside, pushing the diaphragm up or pushing the chest up, you may not be having that much level of analgesia there. Because many times we just keep up to T8 or T7 that we just keep the level there. And when you're pushing the things up, that can also be a part of chest pain. Moreover, anyway, the oxytocin and all those methotrexate are the drugs which have a impact on the cardiac tissue. And there can be due to the, sometime in some patients, which may not be subclinical type of chest pain may be there. The ventricular strain pattern we can see on the ECG also when you are putting these drugs. So that is not a major cause, but the major cause is always the physical one. Because whenever we are manipulating the uterus in such patient, you are definitely moving the uterus in and around that abdominal cavity. That can cause the chest pain also.
Sir, I would like to add something.
Yeah,
If
please.
the chest pain is quite severe, then you should always keep in mind possibility of pulmonary embolism.
Yeah, that differential diagnosis is always there. And I hope, ma'am, this doesn't happen so easily because that's a very difficult to handle them.
Yes.
Most commonly, when we give methotrexate, this is observed, sir. Patient has chest pain
Dr. Ridhima
because
wants
of
to add
some
something.
amount of ischemia.
Yeah, I just want to ask that in 2005, they have done one study to see whether methotrexate aggravate chest pain. They found no relationship, and they said, but we should not exclude the possibility of coronary spasms. Sometimes
Yes.
it can cause tightening and small coronary artery spasms.
There
So
are
we
some
believe
studies
that,
which
but
have said that it causes coronary spasm.
yeah, but the direct association has not been so far included. So holistic approach should be there whenever the patient complains for that.
That's what I said. Ventricular strain pattern is there sometimes. So because that strain pattern occurs because of spasm only, and that I think you have to be very much careful during that particular period. Shima, next question.
Yes, sir. So, how do hemodynamics change after spinal? Should we have invasive lines? What is the recommendation about having invasive lines?
Invasive lines.
In obstetrics,
Section.
I don't think we.
I think 99% of the cases in India are done in periphery, so many times. I don't think so you require invasive lines such. Definitely the patient's having some cardiac tissue problems, the cardiac disease, or maybe a severe comorbidities with the respiratory involvement and cardiac involvement, which are almost done in the institutional setups. There may you require invasive line to monitor such patient. Otherwise, I think the God has given, these are young patients. These are young patients. I think majority of patients are below 35. Majority of them, 90% of the patients are below 35. In these patients, the compensatory mechanisms are adequate enough that you don't require these invasive lines. But when cases of hypertensive or the abruption or antepartum hemorrhage are coming to you, it is always prudent to at least secure two large vein cannulas. This is a golden rule I think we have been following for right from the teaching in our postgraduate career till today. So having two lines will always be helpful in such cases. That too before starting even the anesthesia procedure. And I think Dr. Sunita can add something more to it.
Yes, sir, very true. We are working in tertiary care hospital and just cesarean sections are pouring in. So it's difficult to put invasive lines unless and until it is really indicated. Otherwise, as sir, you have said that we should have two large bore cannulas inside to manage with IV fluids.
Definitely.
Ma'am, one of the questions we have, what's the target BP while we use antihypertensives in severe PIH?
I think we should stick to 140 to 90. It should not go below 140. and diastolic should be 90 to 95. We don't want drastic, we don't want to make patient normotensive.
Yeah, that is important because the patient's threshold, the mean arterial pressure, all the organ supply, the organ perfusion pressure is adjusted to that particular level. And if you want to decrease make it more a normotensive, that is almost a hypotension in such patient, because that is a major percentage of fall from the baseline. Baseline is the PIH pressure, whatever we are getting. So anything below more than 25% fall will be detrimental, I'm telling you, patients from the baseline.
What should we give as muscle relaxant, vicuronium or atracurium?
I think whatever you have in your trolley, that is good enough.
So is there a minimum time you should take to reduce BP? Like patient came with high BP, and then is there a minimum time you should take to reduce?
I think 30 to 60 minutes the BP should be reduced, because again complications like intracranial hemorrhage, chances of hemorrhage, IC bleed can increase. So you have to take action within the period of 30 to 60 minutes.
That's a good time actually. You can get the whole patient operated also between that time.
Yes.
So last question is, can we use fresh whole blood for coagulation factors?
Yeah, that's the best question, until date. The idea is we resorted to that PRBC for a long, long time now, last 10 to 15 years. We were following the Western countries. And now suddenly there's a long drift, the drift change in the Western nation. They are using the whole blood nowadays rather than the PRBC or the washed RBC. They are resorting to that. So what we were following at that time, we were following the Western country, their guidelines. So we were doing very good thing, because in our seniors, whatever we thought with the clinical acumen and the clinical skills with experience, they always say, whenever you are giving the whole blood in such patient, you are optimizing almost every protein of the body, almost every nutrient of the body. You are almost every cell of the body, you are optimizing with the whole fresh blood. When we are going for the PRBC and other things, you are missing so many things. So things have gone back again to the new era, where the Western countries have started using the whole blood, and we are still sticking to many places the PRBC, just like the indications being given on the guidelines and the protocols. So whole fresh blood is the thing nowadays. It's acceptable universally at an international level also.
Sir, I would like to add something.
Yeah, please.
Nowadays, we don't get fresh whole blood because blood banks are not giving blood unless they do NATO testing and all that. And it takes almost 24 hours. So I don't think we get fresh blood. So whatever whole blood we get will cause allergic reactions. And I don't think it is good to give whole blood if plate components are available. If they are not available, of course, we can think of giving whole.
No, ma'am, actually, if you go for the testing nowadays, we have got so many good tests where everything can be done in 5 to 6 hours. Just have to wait for rather than 24 hours. And the allergic reactions, ma'am, the allergic reaction, the incidence, if you go for the whole blood, if you see any hair sand, it was there. You are definitely right. It was there in the previous times when we replaced the whole blood with the PRBCs. But with the current literature and the current evidence throughout the world, people are using the whole blood. The whole fresh blood we are talking about, but the whole fresh blood, we have got so many good tests, so many good machines are there, the component therapy machines. Along with that, we are getting so many good equipment where we can easily make a whole fresh blood available within 6 hours. So that is also, we have given in our own institution also, that machine is there where we can get this blood and free of all allergic reactions and all the free of infection. So that I think, ma'am, is a little controversial thing, but it is being followed throughout the globe now. People are following us actually, the Indians there at the international level. I think we also want to follow that and they follow us. Next question.
One question is about maintenance fluids in pre-operative and intraoperative period.
Pre and intraoperative period fluids.
Maintenance fluids.
In this patient or in patient of PIH?
In patient of PIH, ma'am.
In patient of PIH, we should use Crystolide in the form of ringer lactate, and even we can use normal saline. In our patient, we will definitely prefer normal saline as this patient is having gestational diabetes in addition.
Any ERAS protocols?
Of course, balanced salt solution is available, then it is the choice.
Balance of solutions.
Ma'am, one of the question is, are there any ERAS protocols?
And Dr. Madhuri will answer this thing. She is expert in this ERAS protocol for such patients. Yeah, Dr. Madhuri.
Yeah, I think ERAS can be applied anywhere. We can apply it anywhere, and just depends upon what steps you're going to apply. You can apply ERAS protocols. What is there? The same protocols which are there for lower segment cesarean section. You can apply.
But in PIH cases, one thing is there, as you see the pathology, how it subsides. Pathology, how it subsides, how the patient regains to a normal level, the pre-pregnant levels, maybe just near to pre-pregnant levels. And, I think ERAS may be a little difficult for PIH patient with gestational diabetes and anemia. But overall, if you see all the patients with solely PIH, I think they get, almost you can apply all the protocols of ERAS on such patients. But little difficult on diabetes mellitus.
What I think is more than ERAS, patient safety is more important here than
that is more important.
Going in for an early recovery, isn't it?
Yeah, definitely. That's the first time I'm agreeing with you, like no large scale. The patient safety is the most important.
Yeah. Ma'am, one of the questions is, are PIH patients volume contracted or overloaded?
Contracted.
Vishali, Vaishnavi and Pratusha.
Sir, yes, sir.
The question, answer it now. You want to some medals or not?
So question, sir.
Repeat the question.
Are PIH patients volume contracted or volume overloaded?
Volume contracted, sir.
The reason?
It's leak. As leaky capillaries are present, there is increase in vascularity in the capillaries. So volume should be restricted.
No, that's why I'm asking the mechanism of the volume contraction. Dr. Madhuri wants to add something.
I don't think they have answered it correctly, Vaishnavi. Are they volume? The question is, are they volume contracted or are they volume overloaded? That is the question.
Yes, ma'am.
PIH. So what is the basic problem what is the basic physiology in PIH? There is an intense vasospasm throughout the body in each and every organ. So when there is vasospasm, what will happen to the blood volume?
Decreases.
Will it increase?
Decreases, ma'am.
In PIH, there is hemoconcentration, right?
Yes.
Then what will happen to the blood volume?
She's giving answer on your behalf.
I gave you the answer also. Half of it I gave you the answer. What is the hemodynamic profile of a case of PIH? What are the hemodynamic changes which can occur?
See, Vaishnavi and Pratusha, don't panic. These are gold medal questions. You want to have a gold medal with this paper? So just go ahead.
In early stages of PIH, vasoconstrictions and decreased plasma volume is there, ma'am. So, and also there is reduced renal blood flow and glomerular filtration rate. And increase in sodium and water reabsorption.
So you go only to the cardiovascular system.
As simple answer is intravascular volume is contracted state. As simple as that. Okay?
Yes.
Intravascular volume is contracted state in these type of patients. She already gave you the answer.
Yes. And the systemic vascular resistance is very much elevated. It is disproportionately elevated. with an increase in the cardiac index also, right? Okay.
Yes, ma'am.
Okay.
So like any hypertensive patient, here the volume is contracted.
Yes.
Like in hypertensive patient, there is contraction of the intravascular compartment. The same way in PIH. Right?
Any other question? Shima?
Yes,
I think questions are finished, Shima.
No,
Can I
no,
ask? Can I
we
ask
have
one question?
No, Dr. Madhuri, we have to depart
Fine.
because there
Okay,
will be
no.
online
ठीक है,
GC
ठीक है.
meeting is also there.
Okay,
I have
okay.
to start with the GC meeting.
Okay, okay.
And then before that, proceeding for the GC meeting, we have to honor our faculty today. My screen is visible to everyone?
Yes, sir.
Yeah. So the biggest
Yes.
captain today is our captain, Madam Dr. Sunita Sanklecha, ma'am. So she done a wonderful job, prepared her team very well, and both the girls were very, very good in answering almost everything. Just missing on the gold medal question. But that was a thank you, ma'am, for preparing such a good team. And the topic is actually complicated. If you ask me, PIH with the gestational diabetes with anemia, and sometimes with the patient with the scissors, pre-pregnancy scissors also. Thank you, ma'am, for being a captain in this inning.
Thank you, sir.
Yeah. And then Dr. Jayashri, ma'am, yourself,
Thank you, sir.
Dr. Kashinath, sir, and Savani, ma'am, all thank you very much as a faculty to prepare your team and you answering almost every question in such a good manner and a good discussion today.
Thank
And
you, sir.
Vaishnavi and Pratusha, you did a wonderful job.
Thank you, sir.
So don't worry, that one or two questions nobody can be perfect in answering. Those are difficult questions at your level. So when you become a senior resident or second, third year, you will be able to answer such questions. Okay. So thank you much for such a good student of the class today. Then
Thank you so much.
Shima was good in anchoring right from the beginning, and
Thank you, sir.
and so was Anu also. So thank you to both of you being the
Yes, sir.
screen coordinators for today. And then we have our own people that Madhuri madam being the class coordinator along with Dr. Nishant and Ridhima. They are always there as a class coordinators that they develop the protocols for these classes. So that's how they go technically so smooth. That's the best thing we are happening to these classes. There is hardly any type of a technical glitch. So they are very helping. Thank you to all of them. And to the entire audience also who have been sitting right from the 6:30. It's almost 8:45 now. So it's a long session today, but very useful and productive. Highly go for both the students and the practitioner and academicians. So I think that's time to say goodbye now. Nishant appear ho gaya abhi thoda sa. So I also have a GC meeting just now after 9 o'clock. So it will be a long meeting again. That's why I have to curtail the things here. Otherwise, the discussion would have gone another 15-20 minutes. So thank you, everyone. And thank you for being a part of such a good class. And it will be available on ISA NHQ at YouTube when the class gets over. So you can watch it. It's recording there. So
thank you very much, sir, for giving this opportunity to our students and for us also.
Yeah.
Thank you so much.
So, now time to end, and we always end by saying long live ISA.
Yes, long live ISA.